All right, well, I'm going to go ahead and get us started. Welcome, everyone, and we're so glad you're here. I'm Liza Greenberg. I'm a quality consultant for VNAA. I work on our VNAA Blueprint for Excellence, and if any of you have not seen the blueprint, we encourage you to take a look at it. It's got a lot of quality strategies relating to Impact Act measures and star ratings, as well as chronic care management, so it's relevant to the session we're having today. So I wanted to welcome you to our session, Mobile Technology for Home Healthcare Patients, presented jointly by the Alliance for Home Health Quality and the VNAA of America. The session is being recorded, and I'm going to read the nursing disclosure statement, but I also wanted to let you know that there is a sign-in for those of you who will be looking for contact hours, so make sure you sign in either over where I'm sitting later or by the door. So this continuing nursing education activity has been approved for one contact hour by the Maryland Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive your certificate of completion, you will need to attend this program in its entirety and complete the evaluation, which is in our mobile app. And just FYI, the slides are also in the mobile app, and we can help you figure out how to get to them if you're not familiar with the app yet. Our faculty has disclosed no financial conflicts of interest, and a copy of the full disclosure sheet is available on the table outside your room, or there are also a few on the tables in front of you. And I'd like to introduce our presenters today. So Cathy Guttman is Vice President of Home Health and Post-Acute Care for Medocity. Medocity is a leading software and services provider specializing in virtual patient-centric care management. In her current role, Cathy is responsible for end-to-end oversight of Medocity's solutions for home health and other post-acute care providers. In addition, she supports Medocity's positioning strategies and future growth plans by identifying trends and regulatory developments that impact key business lines within the healthcare delivery ecosystem. She develops learning modules and delivers presentations to the sales team on healthcare landscape and payment models. Prior to Medocity, Cathy had 25 plus years in various healthcare executive and operational roles. So we're glad to have you. Thank you. And Robert Rosati is chair of the Connected Health Institute and vice president of data research and quality with the VNA Health Group in Red Bank, New Jersey. He is responsible for implementing and evaluating new technology initiatives at VNAHG, and he's responsible for quality improvement, analysis, reporting clinical outcomes, and conducting research related to home and community-based care. Prior to VNAHG, Dr. Rosati was at Centerlight Healthcare provider and managed long-term care plan in New York, which runs one of the largest PACE programs in the country. For over a decade, he directed the internally funded research program at the Visiting Nurse Service of New York. His healthcare experience is varied widely in research, quality management, education, and administrative roles. And he's published over 40 articles. So thank you both for being with us, and I'll turn the mic over to you.
Okay, we're good. Thank you. So I'm glad you're here, and I understand there's stiff competition for our time slot, so I appreciate you coming to spend at least an hour with us to hear what we're doing. So today's discussion is going to go back and forth between Cathy and I, and one of the things I want you to think about up front is this has been a journey in many ways and a learning experience for both Medocity and for VNA Health Group in trying to implement technology where we put app in the patient hand so that they can utilize that app for multiple functions and really, in my mind, and I'm sure in Cathy's, better interface with patients so that we can coordinate care better, communicate, and also know when there's going to be something that we need to address from a clinical perspective. So this started out as a pilot that we thought we would do quite a while ago that really wanted to get at, how do you create a virtual care environment for patients that allows them to get access to resources and also to be able to look at how a company like Medocity and an organization like VNA Health Group can partner to help develop that application and to see how it would work in the field. And so that was one of our goals from this project. The other was really to understand, and this is really something we wanted to truly collect information on, is how challenging is it going to be to deploy an app with patients in the field. You know, we all think about today, we've got our iPhones or we've got our tablets and we've got app stores and we download lots of different things that we utilize, but we're talking about a very different environment here. We're talking about an older population, people who may or may not have the technology that we're all used to having access to, and whether or not it's really doable to say, go to an app store, download an app, and then we're going to communicate with you on that app. So this is one of the things we want to investigate. And then we really wanted to know, if we get people starting to use this, what happens? How does it change the way a patient and a clinician views this interaction? So it's a new way of changing the care delivery model so that we're making this connection through technology, and we wanted to get their perspectives. So just a little bit of background on why we're doing this, the themes that we're going to talk about today. You've heard this morning from many of the presenters about really, you know, where are we heading as an industry? What do we need to do to really make sure that we continue to be viable and important? So if you really think about what's happening right now, you know, aging, the population is, you know, the number of people who are over the age of 65 is growing. The number of people over the age of 85 is growing substantially. Many of the people we provide care to have, you know, multiple chronic illnesses. There are also, you know, lots of challenges that exist today, both from the financial and the policy perspectives, in terms of how we deliver care and some of the constraints that exist. We also see that people are becoming more consumerism in terms of how they view healthcare. So they're trying to think about, you know, what's the best provider, who's the most user-friendly to me, and so on. And then finally, we know that technology is coming into play here. And, you know, a lot of the discussion earlier was about really technology we use to make our organizations run better. But the technology that exists is really coming into play in terms of its interfacing with patients. And I think that that's another area where there's a lot to be learned and not a whole lot of research that tells us about what works.
So again, I just want to thank you for being here with us today. I consider you guys the innovators because, as Bob said, this has been a long time that we've been working together, and what we thought was going to happen turned out to be, you know, very different, and learning and working together. So as an organization, we learned a lot. I want to thank the VNA Health Group for allowing us the opportunity to work together. So I just wanted to, you know, it's funny, this morning we heard a lot, and I was looking at my slides, and the good thing is that everybody has the same theme. We're all talking about technology and technology enabling us to, to do lots of other things and where healthcare needs to go. And then last night, we heard a little bit more about elevating home, which I think is a wonderful concept. And for a long time, I've thought about us as an organization, as an industry in home care, as kind of being thought of as the end. And we're really not. And in today's marketplace and with today's value-based reimbursement, home health becomes really the opportunity to be center of the stage and to really have a voice in where we go. So healthcare, technology really enables to collaborate with post-acute providers and to build somewhat of an integrated system, to be able to go through all the levels of care and to be able to share information amongst everyone so that when things may come full circle, we're all connected for the betterment of the patient. I think some of us might remember the old days when you barely got a fax to know what was going on with a patient when they came onto service. And to be able now to have all that data connected and actually know a little bit beforehand, before somebody comes on to service, what's going on with them. The second is opportunities for home health to coordinate with payers and to continue to diversify the services that you provide to be able to do care management out of an episode of care. I think we had some people talking about that this morning, to be able to reach further into what does a home health agency do. And then to integrate more with providers and work with them on some of the things that are important to them as they move into MIPS. And we talked a little about macro this morning and MIPS and alternative payment models. So much of those alternative payment models have a lot to do with care management, and to be able to have those many touch points with the patient or client in between any episode of meeting with a doctor or an episode of care, and really trying to manage things before they happen, moving from reactive to proactive. And it really doesn't stop there, and I want to add one more point before I get there. This morning, somebody mentioned the discharge, and it used to be that the word discharge meant discharge, and that was it. Close the book, move on to the next person. And now the word discharge really needs to be something that we eliminate from our vocabulary, because we have the opportunity as home health agencies to be able to continue to monitor and do some oversight and care management for patients, opening up a whole new world of opportunity from a business sense. But it also doesn't stop there, and I think, Bob, you alluded to the fact that early on in the age of the patients and, you know, their use and ability to use technology or to even have technology, and we'll talk about that a little bit later. But the whole idea is that the use of technology is increasing every single day. You know, as those boomers get into the home health group, they have an ability to use technology. And other things are changing in terms of voice-activated technology to even help the frailest of the frail. So it continues to get easier for patients to adopt technology. And right now, you know, also the caregivers, so if their caregivers are basically in that 51 to 59 age group, those are the ones that are using technology. So we'll talk a little bit more about how we utilize that.
So next up, I'm going to give a little bit of background on our organization, and then Cathy will talk about hers. But before I do that, I wanted to ask a question before, and I didn't. How many people here have patient portals where they're allowing patients to get access to their clinical information? Anybody doing that? You are. Okay.
I have 4 on my own.
Yeah. Yeah.
Access and never do.
Has anybody ever gone down this path of trying to use an app with the patient?
We've developed one, but more probably the scheduling or requesting or even recruiting basis, kind of the Uber mentality.
That's the key issue, you know, really the key challenges that patients have in those areas. So I think that, you know, just based on kind of the responses here, you can see that in general as an industry, we haven't been patient-focused with respect to how they can get access to information or even reach us via technology. That's not been generally what we've been doing. So this conversation between Cathy and I goes back to April 2015. And what happened was Cathy came in to me, and they had developed an app in another area and said, I'd love to talk to you about deploying it in home health. And when I looked at what Cathy did, I thought, well, they had a great platform, but they didn't really know our industry very much. And so Cathy was very gracious to say, well, let's talk about that. Let's figure out how do we build something that we think would be relevant to the people you provide care to. And so this collaboration and partnership has really been with us providing input about what we think is relevant, and even from a clinical perspective, what should be in the app. And then on Cathy's side, them really trying to develop that into the technology that we would offer patients. And I personally think that's a really unique situation to be in, because I've typically dealt with technology firms who want to give you something off the shelf and are very reluctant to really say, how could we reframe this in a way that we think it's going to be most useful? And I think this has really helped us develop something that is very patient-centric. It really will help us as an organization deal with the way we deliver care today and what can be done in the future. And there's more to be done. I think you're going to hear from us that this is not all a rosy picture. There are some challenges to trying to do this, but I think that the one good thing I would feel about what we're capable of doing is to try to look at those roadblocks and then think about what do we do next. So just briefly what VNA Health Group is we're a large non-for-profit organization throughout providing home care and hospice throughout the state of New Jersey. Our home care census per year is probably somewhere around 35,000. This big number of 120,000 is because we have federally qualified health centers in the state, and we also do a good amount of grant-funded child and family services, community-based services. We also have a visiting physician practice where typical Medicare population, where instead of patients coming into the office, we go out to them.
So me too, we had a kind of a rosy picture of what this would look like, and oh, you know, I have a mom who's 86, and my mother does use an iPad, and she's a twin sister who's 86, and she uses an iPad. But I kind of learned along the way that they were, you know, not the norm to begin with, and again, things are changing. So we had a lot to learn as well. Bob was tough, I will tell you. We came to them with an application called Eye Cancer Health. So Medocity started in 2012, and our first foray into the virtual care market was in cancer. And we launched our first platform in 2014 in fourth quarter. So not too long ago. And from there, we went into COPD and CHF, and then we started to build the technology that you can have any diseases. We didn't have to have all these different platforms, which was really important to the VNA, and was probably part of the impetus for us moving forward that quickly. And that's the kind of collaboration that we had with one another. You know, and when we talk of the words virtual care management, people were looking at us like, well, what are you talking about? So when we started to use the word telehealth, people started to, because the whole concept of using devices to monitor blood pressure or glucose levels, weight, was pretty much out there, and it's very interesting because everybody still to this day has a different name that they call it. So as we started to prioritize what was important, they really helped us to kind of move down a path of what would virtual care management look like in a home health environment.
So now I'm going to get into what we implemented and share with you some data that we've collected throughout this process. And, you know, my point of view on what we were doing was that we really wanted to use the data that we gathered to help really enforce whether or not we were successful, but also to think about changes that we can make over the course of this deployment. So what we were trying to do, you know, throughout the whole project was do this as a pilot where we would bring patients online, our nurses, and roll it out, get feedback, look at how things were going, make modifications where necessary, almost like the PDSA cycles that are typically done, you know, in quality improvement. So we wanted to first think about, you know, how do we enhance the patient engagement through messaging and resources. So we wanted to open up this capability where the patient could contact their nurse using the technology, but we also wanted to put on the tablet or the phone clinical resources that they could tap into so that if they had questions about their care, those would be there. Then we wanted to see if we can improve patient satisfaction. We wanted to make it easy for the clinician to use this application, because think about what we're doing. We're implementing something new that's outside of the care delivery process that exists. You know, they may be on their phones today talking to patients, but they're not responding to text messages from patients, or they're not doing virtual visits with patients. That's not the way they do things, so we needed to consider that. And then, you know, we wanted to see whether or not it'd be possible where we can improve or increase productivity of clinicians by allowing them to use virtual visits at times. Now, we're not trying to substitute for a visit they would have made, but if they wanted to do an additional check-in with a patient, do it in a virtual visit, video, face-to-face, and if necessary, maybe change their visits, going forward from that and go in the next day or whatever. But the idea of introducing that to the clinician was something novel. So we had measures built into this pilot that was going to get at what were they using. So both from the patient side and from the clinician side, what functionality within the platform. The other piece was that we were going to do a patient satisfaction survey at discharge. So when they left us, there were items built into the tablet that they can complete to give us some feedback. And then we wanted to look at nursing and therapist visits per patient. I'm going to share with you data on the first two points here, and not so much on the visit frequency. But before I do, Cathy's going to kind of show you the module. So it makes more sense to see this, then I'll talk about the data we're collecting.
So on the Medocity platform, it has many different components of it, and we didn't start out using all of the ones that are even up here, and actually Medocity has a bunch more. So it's a very modular kind of system that you can grow into. It's very interactive, meaning between the messaging and the televisits and the symptom trackers, there's a lot of interaction going on, which actually kind of leads a lot towards engagement. But it's meant to be one where we're gathering patient-generated health data. And it is one that really complements the care team. It's not meant to replace it, it's meant to complement it. And that's really what virtual care management is. It's those touch points in between when one of the clinicians is visiting them so that the care team knows what's going on. And then their visits become more proactive than reactive. It's looking at trends so that when the visit happens, it's like a richer type of visit and a different visit. And I was really happy this morning to hear the discussion about longitudinal personalized care plans. We built that in. We are not using that right now. And this, for you in home health, this is different than the care plans that you're doing when they're in an episode of care. These are care plans that are patient-centric for the patient when they're actually finished, and it's more about population health, of what can I do to manage and live as independently as possible with a chronic disease that we have. And that's the piece that starts to go into that integrated system as you're working through different care settings and different care teams, that there's a consistency of data and information. So nothing is dropped in that, that horrible hole of transition of care. So I wanted to drill down a little bit more as to what does that look like. Okay, Cathy, you showed us the one, so what does it actually look like? So these are actual screens from what we utilized. And the health tracker, what the VNA Health Group decided to do is not to do it in the beginning disease specific, but to do it as general symptoms, like fatigue, lightheadedness, dizziness, constipation, diarrhea, and the patient would then answer questions. Now, these questions could be daily, they could be weekly, they could be monthly. One of the things that we learned is let's not do them every day because we're really looking to follow a trend line. But the key point, and they could be psychosocial, as social determinants come in. Do I have issues getting my medication? Do I have issues shopping, grocery, doing my meals? Whatever it may be, or just a simple question that we put in the beginning: how are you feeling today? Very subjective, but it gives an idea what's going on at home. And with that, once they answer the question, it gives them some guidance. Now, that's their guidance. Now, this is just a screenshot, so don't read it. But it's the first round. If the patient were to call the call center at your agency, this would be the information they would get. And that's communicated to the patient so they know, okay, here's your comfort level right here, here's what we would tell you to do. And in there, they placed some videos and maybe a PDF of something that they wanted them to be able to view. So it wasn't just words, and then it led to resources. And it would say, please, you can refer to the resources, and now here was a larger library of information leading for them not only to handle their symptom, but more now moving towards knowledge of learning about their chronic disease. And that also videos, so they're in their PT team. What they did is they did these little videos of all the exercises so that when the physical therapist left and wanted their patient to do a couple of little things in between and they couldn't remember, how do you do that chair sit-up? It was very easy because the video was right there. And seniors love to watch the videos. And then with that, we added medication management. And the patients didn't use it, they can, it has alerts, and unless you're on web-based. If they're using a tablet or they're using a phone, it does have alerts. But the whole idea of education, in layman's terms, not trying to read that whole long thing that comes out of the nebulizer when you first get it, who can read that? And so what happens is they put the nebulizer over here because I don't know how to use it. I'll wait till the nurse comes next week. There's 7 days that they haven't used it, chance of going to the hospital. So the information that we put in is really one that anybody could really understand. And then the opportunity to do televisits and teleconferencing. And then this feature of messaging. So the whole idea is that a patient is able to message their care team, having better access, quicker, real time, and if they wanted to share, and what we're demonstrating here is being able to share a picture of something, the nurse responding, and then the patient responding back. Okay, I think that leads on to you again.
So I'm going to address that later, but so we do manually include this information by basically offloading it at discharge and uploading it. So, but it's one of the challenges that exists right now. So, yeah.
Is the messaging, does it have to do with their nurse, or is there somebody that's on call, or is it related?
Okay, so it can be set up many different ways. So you have, the first one is with your nurse. Let's say they also have a PT or they have speech or a dietitian. So it can be set up for multiple people. It could be set up also with somebody else, another part of a care team, that you're part of a hospital system that's taking it on. But your specific question, is it going to an on-call person? No, it's not, and it could. But the point is this isn't an emergency system. This is about managing whatever you're feeling and or what's going on. And most of their guidance said at the bottom, if this is an emergency, call 911.
So maybe you'll get into how quick the response time is.
So we probably, I don't know if we can send data on that, but I think that you're asking a really important question because this is something we've been grappling with. So my initial design of this was to put it in the hands of the patient and their coordinator, their nurse. But it leads me to think, after doing this for a while, whether or not you need to adopt the kind of central station approach where all the messaging is going to one central person who is then kind of triaging the messages. And I'm going to give you a little bit of feedback from our nurses about that that addresses it. But the platform is flexible enough to go either way, where it can be one-to-one or one-to-many relationship. The other piece you haven't mentioned yet is we can also bring in the caregiver. So the messaging could, so the patient can identify a caregiver to bring into that loop, and they can see all of what's going on as well. So I think that's another important piece. And one last thing that I just wanted to say about the technology is this runs on Android, Apple, as well as web-based. So you don't really need sophisticated hardware to do this. If somebody has a computer, they can go on in a browser, and they can do the same thing. Some of the features are not there, but it works basically in any environment. So going back to kind of the pilot we're doing, so we're looking at trying to patient engagement. We want to look at improving communication. Want to look at clinician productivity and patient satisfaction. But we're also trying to get at some other issues through this in really thinking about, like, how do we get clinicians involved? And part of that is also tied to, should we have a champion, a nurse champion? So, pushing technology in itself is really not the way to go, and I'll talk about that. How much training has to be put into place to make this work? And then finally, getting them convinced that there's value and benefit to using this kind of technology. So here's some preliminary data, and what I want you to know is that, I'll talk about the registration process towards the end, but once we got people registered, we got 83% of them active, and that's a good sign. What happens is, in terms of what they utilize when they're in the platform, messaging is their number one feature. So people like to be able to message their clinician. Next up was the health tracker. That's what Cathy showed you about them putting in their symptoms. Then the resources, and then the medications. So the medications module, just so you know, it requires, they call it a medicine cabinet. It requires somebody to go in and put all their meds in, and then it can do reminders, it can tell them the drug information, but that is, a little bit labor intensive on the end user side, because they've got to do that or have a family member help them get it set up. It's a great feature, but it does require that. So here's some data that we got back from our patients. And so this 5-point rating scale, we ask questions about, is it easy to use? And you can see 4.4 out of a 5 is pretty good. The lower ones are interesting when we go through this, and it says, using Medocity made it easier for me to communicate with my nurse. 3.6, not bad. Program was easy to navigate is 4. Using Medocity is useful to my recovery. So you're starting to see their score a little bit lower. They're probably thinking, I got all this other clinical components of the care delivery. This is not as essential to getting better. Questions answered in a timely manner, 3.9. Again, allowed my nurses provide me with necessary care and support. Has a benefit to my care and recovery, 3.2. And then, based on overall home care experience, I would recommend VNA Health Group, 4.4. And then at the very end there, the 5 is, I'm glad to have had Medocity as a free tool to provided by VNA Health Group. So we certainly have a customer service issue here, that people like this, and they would, and they feel that it provides them with a greater capability to communicate at the very least. They may not think it's a great improvement tool, but that's okay. We weren't necessarily gearing it in that direction. So what did people say? We had some open-ended questions. Very easy to message my nurse. I think all VNA should be contacted through this program, so you can see where we might be headed. Being able to send the nurse a picture, that was the example that Cathy gave. They'd like different questions. So Cathy said before, we chose a set of universal questions, but we had patients say, I'm getting these questions that aren't relevant to my disease. So, we may want to change that again. The problem is that it would have been so hard to deploy this thinking about who gets what questions. So that's why we went with this more generic list, but we may have to go in the direction of being more specific, tied to diagnosis. Okay, so on the other side of this, we did this by training nurses in several teams so that they would be ready once we got a patient online to communicate and, and receive the information from the patient. The way we did the training, it turned out that only 36% of them had an active patient, 64% didn't. So we had to do a lot more training than people got on, because, selecting the patient, getting them interested, getting them to agree, cut down the numbers, even though we would identify lots of them in terms of who wanted to use this. So from the nurses' side, what were they doing? And, they were all messaging. They were all responding to alerts that came in because of those questions. They were all responding to information that was being recorded about the medications. They were reviewing it. There was a patient summary that aggregated information to them. They were all viewing those patient summaries. Little less so looking at the resources, and there was some, you could look at trends of vitals and so on. They weren't necessarily doing it here. Again, they've got their clinical record where they're looking, so they're probably not going to go here so much, but this is patient reported, so it still does add value. So again, you know, what was going on here? Not every patient had an alert. 40% of them did. And the alerts are all based on how they're answering. So for example, a pain question has a scale. If they say that, you know, I'm in extreme pain, then there will be some follow-up questions asking them, where's the pain? Have you taken anything? And if they feel like they need help, that triggers an alert. And that was being sent over to our nurses. Now, here's the clinician side of it. And these numbers, if you look at them, are a bit lower. And, you know, there's a lot of reasons why this is the case and a lot of discussion back and forth between Medocity and myself about really what's going on here. So they, from a clinical perspective, which is interesting, don't think this has as much value in terms of helping with clinical decisions, okay? They are also saying that, you know, would it be worth it to, you know, allow people to pay for this? Not as strong about that. And also, they don't feel like it really helps with their productivity. So think about the integration of this technology into the clinical workflow. I mean, that's what this is about. This creates a new challenge for them. Something we need as an organization to think more broadly about. How do we create a real strategy that says, if you're going to get some new information from a patient, outside of your typical clinical workflow, how do you work with it? How do you incorporate it? How do you think about utilizing it? They also think it's a great tool to communicate with the patient. So this is really important. Again, something we're trying to achieve. They also think we should continue to provide it. So even though they feel maybe it's a little bit of a challenge for them and create some extra work, they think we should still do this. Okay, so what do they say? They say, this is great. I can email patients and families. I can communicate with the patient. They commented that that medication log is time-consuming. They got into this, whether or not, you know, it helps them pay attention to which patients. So they said that, you know, the idea is that this can be a little bit of a challenge for patients, and they understood that. Daily check-ins may be too much, reminders and so on. So, you know, we got to temper this a bit. And then finally, you know, what could we have done better here? They said we should have had more information in the admission packet about how to get access to the app. So I know this is a little bit hard to read, but I have to tell you this is one of the biggest eye-openers for me in terms of the challenges of getting this into a patient's hands. Totally unanticipated in many ways. So, you know, we're all familiar, as I said, with going to the App Store and downloading an app. But now, when we were dealing with this, with a population of patients who tend to be older, less tech-savvy, and often relying upon someone else to be their tech support person. You know, we could go in and the nurse would say, we got this great app, we'd like you to sign up. And they say, yeah, that's great. So that took about a minute of time to get through that. Then we'd get that information back. We've got a patient who agrees they want to be part of it, they want to sign up. We had to make a call out and get them set up. We tried allowing them to set it up themselves. We said, here's the web page, here's how you do it. That did not work. So we had to move in the direction of these phone calls. So 10 minutes or so for that contact. We then often had to help people create an account, even though all that meant was use your email and a password that you want to create. You'd be surprised how many people don't have emails, or they said to us, we don't want to tell you the email because they're afraid of spam or whatever. So now we had to think about a creative solution around that. So then, once we got the account set up, now's the procedure of getting it on their device and getting them set up. And, patient couldn't find our email with the directions. They've never downloaded an app before. They said, my son, my daughter does that. They didn't know the App Store password. They didn't know the Wi-Fi password. The device had gone off the Wi-Fi, and they hadn't realized that for several weeks. So another 30 minutes of hand-holding to get the app running. Okay, then, they get into it, and now we're doing technical support because they can't figure out what to push. And you saw the graphics there. That's not very challenging, but it is to some people. So another 15 minutes sent there. And then sometimes we'd get a call back and they'd say, can you walk me through this again? So another 30 minutes of walking through. We only kept the nurse in the process for that first initial contact. We took it back to ourselves to do this work with them. That, on average, was about an hour and a half to get a patient set up. So, I think this is great technology and where we want to go, but now we have to consider that if we're going to try to do this and have people bring their own device and help them get it set up, we need to staff it from a technical support position here that we can get them working. So just beyond what you would have expected, I expected this would have taken, but it is really what, initially, just so I tell you this, we did have the nurses try to do some of this, and they just said, no, this is really beyond what we can do. So we had to kind of go with somebody else doing this back-end work. I think that's, okay. Whoops. Okay. So just some of the things that we changed as we were gathering data, and one of the things we discovered was, given that process that we went through there, and people who didn't have a computer or a tablet, we decided we were going to have loaners. Okay, so we bought some tablets, we set it up for them, and we gave it to them. Much easier way to go, but a lot more expensive in the long run to go in that direction. So we came up with a number of training enhanced tutorials for patients so that they could understand the technology, not so much using the app, but understanding how to do this stuff. We did realize that there are people that just have from either a cognitive dexterity or a vision problem, this may not work for them. And what we tried to do there is when we had a caregiver in the home who we thought could use the app with them, we'd go in that direction. But no matter how much we tried to blow up the size of the fonts or even make the buttons bigger, there are certain people that just have trouble doing that. And I think that's just a reality you're always going to be dealing with. So we talked a lot about the onboarding time. So where are we going? What are some of the other things we're going to do? We're going to continue to think about rolling this out with more teams and really learning more about it. We have tried to push this now back into the hospital. So if we've got liaisons in the hospital, introduce it there with the patient and the family. And then we have discovered the biggest way to make this a success is to find a nurse champion, someone who really buys into this and wants to do it. So, summarize here, and so we think that what we've discovered is that both patients and clinicians find this valuable. They see benefit. We've had, we find that the messaging component is very useful and that people feel comfortable with it. The staff did respond that they felt the platform is useful for staying on top of what's going on between visits. They didn't feel it is an important tool to improve their recovery. Caregivers have shown a lot of interest in using the platform so that they can stay connected to the team. And getting patients set up using their own device takes time. Okay.
So Thank you, Bob. So from our perspective, some of the things that we learned to bring forward to working with other organizations was that this is all about patient data, but it's clinician-led. So it really is all about the clinicians and getting the clinicians involved and motivating them from the top up from the organization so that they see the vision, they know where the organization is going, they see what part they play in it, so there's better buy-in from their perspective. We spent a lot of time on the tools for the patient, realized that the opportunity is also there. Even though we did training for the nurses, it needs to be a different kind of training and more involvement from the organization than Medocity doing training of the team, how to use it. Again, some of the things is, and I'll talk a little bit more about changing how we do things in general. The continuation of training of the nurses. A weekly email we had suggested to tell them what was good, what we learned that week, things that might be broken and how we fixed it, because always with technology, there's something. Teaching them things that they didn't notice before. So many, in the VNA, they were using Samsung tablets, and up in the left-hand corner, you can pull it down and it shows you all your messages and all your alerts without even going into the platform because the platform's always running. So they loved that, and then they click on it and went right into it. So it's continuing to engage them and retraining them along the way. If you let it slide, so will they. Let me go to the next one. And that patient satisfaction, as you saw, can be very high. And this was early on, and there's still a lot to get the patients more engaged. But I will tell you that it all depends on the clinician. If the clinician is not going to use the platform, either is the patient. So it's really important that the clinician also knows their patient and what modules they're going to like. You can see they love the messaging. So there isn't a patient who didn't like that. But if it's a patient that's using resources a lot, make sure you're continuing to push resources and opportunities for them to learn more about their disease. And that's the beauty of the platform, is that it's very modular and you don't have to stick to one way of utilizing it. And it really is just one feature that can make a difference. You know, it's these incremental steps along the way in the value of it. You know, what we learned also is a pilot team. It's important to have a pilot team and to then not only have a nurse champion, but to allow the pilot team to train the trainers for the other ones. We all know that nurses like to learn from nurses. And another piece of it is that there should be one more little piece to this that's not coming up. And it talks about that technology doesn't need to be that difficult. And so in the beginning, the nurses were looking for that perfect patient, thank you, that perfect patient that was, 60 years old and was like looking for a needle in a haystack, and they lived in the right town where the first 5 nurses were, which was crazy. So that's why we expanded it. But so we went back and talked about, so what does the right patient look like to use technology? And what we learned, it was a patient that can use 5 buttons on a remote control. The remote control for your TV. You don't need to know all those buttons, because I still can't figure out all those buttons myself. But if you can do a couple of those buttons, we can teach you how to use the technology. And that as the patients got more, and the clinicians too, as they got more comfortable, they start to explore more about the platforms. We were just starting to get questions about the videos and all of that, because they were starting to get more comfortable with it. So a little bit about next steps for all of us together. And it's about just not layering technology in terms of what you were doing. And Bob and I had a million conversations about clinical workflow and that it had to fit in, and it just couldn't be somewhere out there because they're never going to do it. So it really is about looking at people's responsibilities. It's working at workflow, resource allocation, and redesigning how care is delivered. All those gears lead to a successful introduction and adoption of technology. And I'm so glad to hear Bob say about instead of the nurse doing it all, in other areas that I've worked in the country, they have a triage team. And it's really like the schedulers and the MAs in the agency office who are monitoring the dashboard and answering the lower level alerts and triaging it up to the nurse when it's a severity 3 or 4. So it really is about changing the way that we deliver care as well. And I think, so the next step, I think this is your slide.
So, we've got, as an organization, some more steps to take in terms of what we're going to do with this technology. And we've really considered the concept of adding more resources. As Cathy alluded to, we initially tried to do this with joint patients because everyone said, well, that's the best population to try it with because they tend to be younger, they might be a little bit more tech savvy and so on. So we created all this material and videos and so on for the hip and knee replacements. And then we discovered, well, that was a problem because most of those patients cycled in and out so quickly. By the time we got them set up on the app and they were using it, they were getting discharged. So that really, that we had to go back and rethink about, who are we going to gear this to and what should be the right materials. We really want to figure out, is there a way to make this more user-friendly with patients that have the visual and dexterity problems? And then we are evaluating as an organization whether or not it really makes sense to us from an ROI perspective to really buy tablets and give them to patients. Because it's not just buying the tablet and giving to them, we have to have a process to retrieve and clean them and so on. So that's an issue we're going to have to address. We are definitely looking at deeper integration into our care processes and really getting nurses to think about, can they do more of those video virtual visits? We're trying to figure out how to improve the workflows and, look at this as a way of coordinating care across the team. One thing I don't have up here is the challenge of interoperability because, the question came up, you've got all this great information that's, being collected in this app, but can we push it back into the electronic medical record? And that is a bigger struggle than you can, or you probably can imagine it is, because the vendors today in this industry who provide electronic medical records aren't as open as we'd like them to be. So the challenge then is, how do we convince them that this kind of technology is really the future and really what you need to do is to support interoperability and allow that clinical information to flow back? And we're having those discussions today, but it is a problem that I think has to be solved for this really to be successful. And then lastly, what do? We continue to focus on clinical education here. I think you've kind of gotten the theme that we can't do this by just throwing technology into the mix. We've got to get the clinicians on board and understand the value. We are going to work with them to try to make this as easy as possible, but they have a voice in how this works. And I think that's it. Questions? I hope you felt this was interesting, and I think our learning experience is valuable to others. I think what we have discovered here is that if you want to be on the cutting edge, it's a little painful. It can be challenging, but I also think there's tremendous opportunities. And not that I want to send customers to Medocity, but I think what they've done in working with us and learning from us could benefit other organizations down the road. If you're interested in kind of delving into this a bit, they have certainly put in the effort to understand us as a business. Yes?
At the beginning, you said it was important for a home care agency to carry on like day 61 and how to follow the product. So, and then you're now talking about, and their discharge or transitions of care to the home care agency. So are you giving the tablets out right when you get them, or are you waiting till you've done your 60 days and then do it, or what's your time frame? And then your trial, have they all been within the agency, or you actually followed somebody after they left the agency?
So if this is in the early stages when we preferred them to download it on their own device, they can have this forever, okay? The difference that will occur is once they're discharged from us, we're no longer going to be responding to those alerts and and messages, but the resources remain there. If they want to continue to record their meds, that's all theirs. Now, if we can, and this is on our roadmap, bring in the physician, bring in other family caregivers, this could be an active platform beyond the home care episode.
Yeah, I'll just add that that's, in other groups that we're working with, the whole concept of after 60 days and the care management piece is also, it's all there. Back to your question about can everybody be integrated? Absolutely. When we first started 4 years ago, it was the doctor, the nurse, and it was very linear. Now, our way of connecting everybody is, like all over the place because it needs to be. That's what an integrated system is. What we learned is we wanted to do it at first with the nurses. That didn't work. The nurses cannot really go out there, do the assessment, and be teaching somebody how to use it. So then we went to wanting to do it in the hospital with the nurses in the hospital. And what happened, what we learned from there is that I went with his nurses, and how could you do anything? The bells are ringing, all kinds of things are going on. You're in a double room, the TV is going. It's no way for anybody to learn anything. What we found best, it was after the first visit from the nurse, when they kind of understand, I'm on home care, what does that mean? What's going to happen? Now that they've kind of settled in, that was the best time to introduce mobile technology.
So just to follow up, and I'll answer, we discovered 1 week after the initial visit was the best time to do it, because it turns out that first week they're trying to understand what home care is all about. Worst time to be talking about, here's an app that's going to help you with this. A week later, it worked much better. Yeah.
You think about introducing it in their annual physicals, so you're doing it really preventatively, and they get used to it because they're not sick or they didn't just have surgery and they aren't distracted from all that. They're doing it part of their wellness prevention program, so then it's already set up and they're accustomed to it when they do have a post-acute episode.
So that's a great way of introducing it, right? When they don't necessarily need it, but they can learn about it. And so what I thought about, even from our perspective as an organization, what we should do is put a link up eventually on our homepage. Let anybody download it, right? Get to know it, get comfortable with it. And then when they become our patient, we turn on the functionality that's, so that's really a good point.
That was my question, was one, you identified best user as far as a patient, but what about the nurse? Were the nurses that scored you higher on their satisfaction, were they younger, more accustomed, did they grow up with a smartphone in their hand versus the older ones who are just having to learn it? And also, just do they use other apps? Do they bank online? Do they use their smartphone for banking? And that's, again, a lot of people use that analogy of banking. No matter what bank you use, it's pretty similar technology, and we've got to get that point with healthcare, so you're using it before you have to.
Well, I kind of use that analogy when we introduce this, and I tell everyone that if you think about banking today, right, you would never go to a bank that didn't have an app, right? That's what we do. And I think that eventually that's what's going to happen to us as an industry, because it's happening in other offices that you go to, the doctor, the dentist. They all have an app, and we may not use them that much, but they're there. So it's true. Did you have a question?
So you haven't really tried day 61 or looked at pricing or anything like that? So
No.
what you're doing is you provide a tool for your nurses at this stage. It's just makes them visit and you get the virtual visit. You haven't gone that other step yet.
Yes, and the part of the reason we've not gone beyond 60, the episode, is we do have to consider regulation here, because we can't leave this as an inducement for people to necessarily come back to us, so we have to be careful about that. So we've been struggling kind of internally to think about, how do you let it just exist and not influence where, from a regulatory point of view, we're going to get ourselves into trouble, Yeah.
So I just want to add that to your question in the back, we work, besides with home health, we've worked with lots of other provider groups as well. And that whole concept of the annual wellness visit and going into CCM, chronic care management, code 99490, is something not only do we do from a technology standpoint, we also have our own call center that's handling that 20 minutes, that 20 minutes of care, plus our work with CPC Plus in alternative payment models. So, this was a great, we will continue to move forward. We've learned so much, and we have so many ideas. But the whole idea, again, of technology is also what we talked about this morning, and how do we position our organizations to be successful and critical members of an integrated approach to care.
Okay, we need to stop, but if you'd like to continue the discussions, you could take them offline, and these guys might be able to meet you in the hallway. But thank you so much. We appreciate both of our presenters and give them a round of applause.